Yes, Dr. Palani. Yes.
Good afternoon, ladies and gentlemen. Welcome again to another masterclass series of the ICOG on the 21st April. And I'm sure people who have been used to the ICOG masterclass, you're aware of how it goes on. It is usually on the second Friday of every month. And this time it's been an exception because of the last week we had the managing committee meeting. And of course, in Tamil Nadu and South India, it was New Year's Day and Vishu. And so we asked the chairperson, Dr. Lakshmi Shrikande, to push it by a week. And she kindly consented to push it to this particular week. And we have an absolutely interesting session waiting for you. And that is being labeled as laborious or not. And we have 6 topics and with 6 enigmatic speakers who will speak on various topics of recent trends and advances in labor management today. And with that short notice, let me have the privilege of asking Dr. Alka to introduce Dr. Lakshmi Shrikande, our chairperson of the ICOG, to give a short overview and start the proceedings. And Alka has been the, can we have Alka's slide, the previous slide? Alka is an assistant professor at the Sri Ramchandra Medical College in Chennai and my own college, and she is from Mumbai, and she is well known to the people of Mumbai, and she knows everybody in Mumbai, and she's been working with me for quite some time and interested in high-risk obstetrics and endoscopy and have research publications. And Alka has been an absolutely impressive worker here, and so Alka will be moderating today's entire show. And over to you, Alka, to introduce Dr. Lakshmi Shrikande and take on the proceedings.
Thank you so much, sir, for your kind introduction, sir. So I take this opportunity to welcome Dr. Lakshmi Shrikande, ma'am. She is well known to everyone. She is the chairperson of our ICOG committee. Sorry, sir. She is also a national corresponding editor of Journal of OBGYN India Jogi, National Corresponding Secretary Association of Medical Women India, founder, patron, and president of ISOPAB Vidar chapter, chairperson of IMS Education Committee 2021-23, president of Association of Medical Women Nagpur 2021-24, Nagpur Ratan Award at hands of Union Minister Shri Nitin G. Gadkari, received Bharat Excellence Award.
Correction is lost, I thought. Yeah. Dr. Lakshmi Shrikande is President Association of the Medical Women Nagpur, and we just recently had, yeah, Alka, you are on, go on. Yeah.
Yes, sir. Sorry, sir. Sorry for the interruption. So she also has received a Bharat Excellence Award for Women's Health. She has received Meru Dara Hansoshia Best Committee Award for her work as chairperson in HIV or AIDS Committee FOGSI 2007-2009. Received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child, and also a senior vice president of FOGSI in 2012. President Menopause Society of Nagpur 2016-2018, president of Nagpur OBGYN Society of 2005-2006. She has delivered 11 orations and 450 guest lectures, and she has plenty of publications in her 30 national and 11 international journals, and sensitized 2 lakh boys and girls on adolescent health issues. She's a medical director of Shrikande Fertility Clinic in Nagpur, Maharashtra. I welcome you, ma'am.
Thank you, Dr. Alka, for your kind introduction. And very good evening to one and all. You can stop screen sharing, Alka. And I'm so happy to be back once again with our ICOG Masterclass. And this time it is Obstetric Masterclass. And Dr. Palaniappan, as convener, has given a very catchy title to this Obstetric Masterclass, that is laborious or not. So I would like to have answer from all of you after this masterclass is over. And the topic chosen by him are very, very practical, are useful to each one of you in your day-to-day practice. As you can see, he has chosen 6 topics, that is LCG, epidural analgesia, routine episiotomy versus restrictive episiotomy, ventouse, forceps, and deep transverse arrest. And the speakers are all hardcore obstetricians, starting from our secretary, ICOG, Dr. Ashok Kumar, Dr. Akila, Dr. Shaijus, Dr. Parag. Last minute change, instead of Dr. Ashish Mukhopadhyay, Dr. Parikshit Tang will be taking your lecture on forceps, and deep transverse arrest is by Dr. S. Sampath Kumari. So I would like to thank Dr. Palaniappan as a convener for this OBGYN masterclass that month after month he's coming out with a very good module with nice topics and good speakers. I take this opportunity to also welcome our moderator for today, Dr. Alka. Yes, nice to meet you, Alka. And
Thank you.
all the attendees who have logged in for this masterclass. So happy learning, and back to Dr. Alka for further proceedings. So we are starting with our scientific session. Yes, you can introduce Dr. Palani and then introduce Dr. Ashok.
Yes, ma'am. So I'm very glad to introduce our beloved professor, Dr. Palaniappan sir. He is our professor and unit chief
Alka,
of...
thank you. Thank you, Alka. I think we'll not waste time. I'm sure the inmates here know me and Dr. Lakshmi Sri Kandaya. Thank you. You can move on to the most important session, the academic session. And
Sure, sir. Sure, sir. Sure. So without wasting any more time, our first session will be all about labor. And the first session is going to be on labor care guide, help or hype. This will be done by Dr. Ashok Kumar sir. He is a director and professor and head of Department of OBGYN, Atal Bihari Vajpayee Institute of Medical Science, and Dr. Ram Manohar Lohia Hospital, New Delhi. He is also a secretary of ICOG 2123, editorial board member of Indian Journal of Medical Research, Archives of Gynaecology and Obstetrics, and interested in maternal.
Alka, I think your connection is getting lost in between while she's speaking. Yes, and it is indeed an honor to have Dr. Ashok here.
Thank you so much.
Yeah.
I will start.
Yes, sir.
No problem.
Alka, would you stop sharing, Alka?
Okay, I will start. No problem.
You can, but she has to stop sharing for you.
No, I will do it.
Yeah.
I think my screen is visible and I am audible.
Dr. Ashok, your screen is not visible. We are seeing Dr. Alka's screen. Just a minute. I think she has to. Yeah, now you are able to see your screen. Yeah, go on.
Okay, so first of all, good afternoon, good evening. Thank you, our President, Dr. Lakshmi Sri Kande, Chairperson of ICOG, for a very good initiative on this. A lot of web series has been started, and we are flooded with all the academic activities throughout the month. And in this series, I'm thankful to Dr. Palaniappan for giving me an opportunity to discuss labor care guide, help or hype. And dear friends, my seniors, my colleagues, this is an opportunity to highlight the advantages and the problems of labor care guide. As you know, there are many complications during labor and delivery. And these complications are 1/3 about the maternal death, 50% times stillbirth, 1/4 neonatal. These are all data from the literature. And these things are more so in the low resource setting, but these complications are largely preventable by timely intervention and monitoring of labor and childbirth. Early identification and treatment of complication will reduce the morbidity and mortality associated with these complications. And it is very important. And now the emphasis is on quality of care around the time of birth. And we are all putting all efforts to improve the quality of care. As you know, we have very most popular labor monitoring tools, Partograph, which is there, and we all are aware of these Partograph. Trained healthcare professionals have been using it to provide care during labor for more than 40 years. However, WA has in 2018 put new recommendation on interpartum care for supervision for pleasant birth. And we will go into these terms. And their recommendation on intrapartum care for a positive childbirth experience. So now the emphasis on positive childbirth experience by the lady. And the principle for these recommendations that through the use of effective labor and childbirth practices and with emphasis on avoidance of ineffective practices. Health personnel can support women to achieve their desirable physical, emotional, and psychological outcome for themselves and for their babies and for their families. So here, families and everyone is very important. So these are the manual for WHO positive childbirth experience, and their purpose is to improve the quality of essential intrapartum care. And they have included 26 new recommendations, and they have old recommendations also. And from labor onset to the postnatal period, these recommendations has covered the areas. And if you see in this, it is very important to understand that it will assist health personnel to promptly identify and address emerging labor complications and prevent unnecessary use of intervention in labor. Simultaneously, it will support audit and quality improvement of major labor management. So for whom this labor care guide on these recommendations should be used? It is for all women. However, I will go into detail later on that usually labor care guide has been recommended for low risk women, but it can be used for high risk women also with additional monitoring and care. Then when should be initiated? When women have entered the active phase of first stage of labor, and then this depends on, now they say it is cervical dilatation 5 centimeter or more. Where it should be used? LCG is designed for use at all levels of care in facilities. That means for all settings, it is practical to use. Now, you know, this labor care guide promote woman-centered care. It is basically patient-centered. It is in the interest of the patient, and it stimulates practitioner to think critically around labor decision-making. And therefore, it individualizes labor monitoring. So from the doctor point of view, from the obstetrician point of view, it is specifically directed to a particular woman in labor, and it is applicable for that specific woman. You know, it addresses length of labor, it identifies when clinical interventions are necessary, and it focuses on keeping the mother safe. And there are 7 portions of LCG which were modified from the original partograph layout. One is identifying information and labor characteristic at admission, supportive care, care of baby, care of woman, labor progress, then noting down of medication, and lastly, the shared decision making. It is important to note that here the care of the baby is also included, and shared decision making means whatever decision a obstetrician is making is in keeping in mind and informed the patient also, and taking into account her opinion also, her wish also. And you know, this is the labor care guide, and it has 7 sections, as I told you. Let's see what all these are important section. You know, section 1 starts with the demographic detail. It identifies the patient, and it also identifying whether patient is an active or whether membranes have been ruptured and what are the risk factors. Then it provides feature for the monitoring of use of supportive care intervention. This is also important. These are all added in this labor care guide, such as presence of companion, what are things have been done for pain relief, what about oral fluid, what was the posture of the patient. Then it also take into account the threshold values to trigger action following all maternal and fetal assessment. If you see here, they've given the threshold values like caput 3+, molding 3+. So these are the cutoff. If these are the alert, if one is going beyond that, then one has to be careful and taking actions. Then it is also documenting numerical values for monitor parameter for pulse, BP. It gives you the actual values also at that particular time. You see, if on the horizontal side, you see it measures the time also, right? So another feature is that it removes the 1 centimeter per hour threshold of cervical dilatation relating to the alert and action line as was there in the earlier partogram. Here it is relating the dilatation of the cervix as related to the time period. Whether this dilatation is staying there for a long time or not, that is the observation has to be made. And then note down the medication, whatever is there. And then you do the shared decision making. You do the assessment and plan in consultation with the informed and the counseling of the patient. And you explain everything to the patient and her companion, and then prepare and share decision. Now, the important thing which is to realize that it needs proper training before we start, because there are many standards are there which have to be applied. So one needs proper training before the use of labor care guide, and supervision is needed in the early phases so that you are not on the wrong side. You are not filling up the wrong information. You are not evaluating in a wrong manner. So that is very important. Therefore, in brief, if we say what is labor care guide, it is a good quality and evidence-based clinical care. It is a respectful care during labor and childbirth, irrespective of the setting or level of health care. That means it is applicable in all settings. Now, let me talk about partograph also. Earlier partograph, Friedman, alert and action line, and then they assume that there is a linear progression at the rate of 1 centimeter per hour of the cervical dilatation and descent. But if you compare these two, on the left side is the labor care guide, and on the right side is, the old partogram with alert and action line. And if you see, there are many differences. And these differences are very important. In labor care guide, you are starting from 5 centimeter. Your proof-based time restrictions on cervical dilatation at each centimeter. You are keeping a track of frequency and duration of the uterine contraction. You are monitoring the second stage. That is also important because that was not there in the earlier partograph. You are putting emphasis on the companionship during labor, pain elevation, oral fluid intake, and posture. And these all are recorded in the labor care guide. And it requires the observation to be noted along with the provider recording the appropriate response. So you are recording the observation as well. What has been done also is recorded in the labor care guide. So these are the important things which differs from the earlier partograph. And if you see further, in earlier partograph, they have ignored the variation in women progression rate. See, not two women are same. All will have different, little bit variation. So that is the important thing. In the old partograph, action and alert line at the fixed hours, 4 hours. So in this labor care guide, it is a it is taking care, and they are using it in a dynamic manner. And instead of setting constant rate boundaries for overall labor active first stage, contemplation for interruption is governed by a proof-based limit of the time for every inch of dilatation of the cervix, which is acquired from 95th percentile of labor span at various centimeter stage in a female with ordinary perinatal results. So it is very important that they have taken into consideration the variation, and up to 95th percentile, they are readily accepting to be a normal phenomena. So it was basically designed to be used for care for healthy pregnant women, but it is important that you diagnose abnormal labor, such as slow progress, by regular assessment throughout labor and document your care program, because this is important for both good clinical practice and for legal reasons, because until you are not documented it, you may have problem later on legally. So it is very important that documentation is needed at this hour in the labor room. And then up till now, if you understand that what is labor care guide and what are its features, then people have objected and they have further gone ahead and they have questioned that will WHO labor care guide have a positive effect on the objectively measured health outcome as well as patient reported measure, because ultimately we are all interested in the outcome, a good maternal and fetal outcome. So whether this labor care guide it has lot many features, but whether it is useful, it is giving a positive effect or not, this observation have been made. And while we are making these observations, there are few important points have come into picture, that there are different drivers for current practice. Like for an obstetrician, what is his or her setting of the center, whether it is public, free, private, paying, whether the center has all the resources. For example, the center has facilities for labor analgesia, general anesthesia, or instrumental delivery, or blood transfusion, so many things. There are differences in culture also. Then everyone is nowadays concerned about the litigation. Then there are changes in practices. In some center, they induce the patient for some indication, or sometimes there are changing expectation of the society also from the obstetrician. So medical intervention during childbirth are generally intended to prevent adverse outcome. This we know, but they are associated with risk. Therefore, intervention without good indication are not justified. But if we expect to have low intervention rate, at the same time no adverse outcome, probably that is not possible. The second is, this new recommendation acknowledge variability in the duration of first and second stage of labor. Whether with this, are we really impacting the rate of labor dystocia or intrapartum cesarean rate? This is a question we don't know at the moment, but most of the women want a normal birth with good outcome. Now, this good word is also not defined in labor care guide. We don't know what is good. A debate is needed about what outcomes are important and up to what extent patient reported outcome as an expectation should drive healthcare practices, because that is important. Now, everything is patient centered. So patient reported expectations, how far we are going to accept in defining the outcome for mother and the baby. So these are all things are now debatable for labor care guide. Now, another thing is, when we are talking of patient sharing and patient-centered approach, and you inform and share the decision making with him, with her, so judgment can get clouded in a stressful and emotionally charged situation. We know in labor room, on one side patient is bearing down, forceps or ventouse is being applied, or patient is wheeled in very fast in the cesarean OT, but we don't know at that time we shared the decision with the patient, how she is going to accept that, how she is going to react to that situation, we are not sure. So at times health outcomes are perfect. We may do anything in the interest of the patient with good outcome, but the patient is left emotionally very traumatized. So we don't know how far this assessment of progress of labor in labor care guide will help us. Another important thing is that we are starting the part of labor care guide from 5 centimeter onward. What about before 5 centimeter? It is very important that clear recommendations should be made that what to do with the patients who are less than 5 centimeters. It is very important that if we consider that as a latent phase or patient with some uterine contractions, the patient should be monitored. We should monitor the mother as well as the fetus. But labor care guide is not very clear about that. Another important thing is, if we are talking of this latent phase before 5 centimeter, or we are monitoring the patient from cervical dilatation more than 5 centimeter, so we should, where to keep these patients before 5 centimeter? We should reorganize maternity units. We don't know what to do with labor companion, which is being recommended now. So we have large number of patients who are less than 5 centimeter with their companion. So we should, or we have to reorganize our maternity units. We have to update our national policies related to the physical layout of the labor wards, equipment and medical supplies, and standard protocols for interpartum care. So this is what is required for labor care guide to be followed. And these are probably, I don't know, are we stretching too much for this? So recommendation about provide care is with dignity is undisputed. We know we have to provide respectful care we know we have to take human views into account when looking after the labor process, but up to what extent, up to what level, we don't know. There might be some personal preferences also, might be influenced by the culture also. There might be some religious factors which may influence the decision making. So we don't know. So how far we will go. So exploring the extent to which the women wish to make decisions about their care would achieve a congruity between women's expectation and their actual experience. Now, this study was done and the result have come about the impact of labor care guide on reducing cesarean sections. And they have found that, yes, it can reduce the number of primary cesarean delivery because you are allowing the patient labor to progress and you are observing the patient. In this study, the cesarean delivery rate was 1.5% the study group versus 17% the control group. There is another, this trial is just starting in 4 hospitals in India, and their primary outcome is the cesarean rate in nulliparous women with single pregnancy, cephalic pregnancy in spontaneous labor, and they are looking at Robson group 1, whether Robson group 1 incidents are reduced by following the labor care guide. We have to wait for the results. The trial is just going to start. Then another thing which we have to consider is what is the perspective of the caregiver, the obstetrician or the health personnel. That has not been addressed in labor care guide, and whether these guidelines will work in our specific practice environment. See, they have said that it is applicable for all settings, but the infrastructure, the facilities, the work culture of each center is different. So whether these guidelines are suitable or working in my obstetric labor ward, I don't know. So we have to just see on this. So these are the things which are need much more attention and debate. So negative concern which have been further added, what I've told you up till now, they have added that it will add to the workload, as Dr. Planet has named this webinar that labor is laborious. Further, by putting partogram or labor care guide, it is becoming more workload. And that is why one of the factors that partogram is not being popular or not being used in a center. You see, in a public hospital where 50 deliveries are happening at one shift, how to follow and how to fill these forms, it a problem. And then tiny space to write, the form is very congested. Then obviously in every center we have very less staff. Always we are in short of health personnel. So how to do this work? And again, we have reluctance to accommodate a labor companion of choice. So that is another problem. So these are all concerned with the labor care guide. And another thing which is with the labor companion is that labor companion should be trained person. It is not that anyone can become a labor companion. So preparing a person as a labor companion is another challenge. So that is another problem. And then addressing social misconception related to the labor companion of choice and practical ways to monitor women in latent phase. These are the issues which we have to take into consideration. So probably when you follow these labor care guide, you need essential equipment also. You have to clear our hospital policies on correct partograph use. You have to have effective supervision, and you have to have regular training programs for LCG. So it might create an additional time burden, and some observation have been made that labor ward cannot accommodate a companion. This is from one of the center. The comment came when the feedback was collected. So there are few things which are important and which needs further consideration when you follow the labor care guide. This study by Vogel et al. Is very important. Now, this person has given a lot of insight into labor care guide. They have done this evaluation of LCG in a sample of 136 doctor, midwife, and nurses from 12 hospitals. They were trained earlier, and then it was applied in more than 1,000 low-risk women. And in that setup, they could achieve 91% vaginal birth and stillbirth rate of 1.6 per 1,000. So it was a very good outcome. And they also observed that they felt that with proper training, practitioners were highly satisfied to monitor women in labor. LCG was a coherent and streamlined tool that prompted them to make more precise, accurate documentation during labor. And their experience was more positive with practice. Initially not, but yes, with the more use, and because they were trained, they were supervised, and after some time they were more confident in using the labor care guide, and they improved the quality of care provided to the women. So what I will say in the end, that this WHO Partogram Labor Care Guide is a women-centered alternative tool, and it is a necessary that continuous future work on this tool is needed to modify or seek any practical modification and to ensure that it gets its expected impact, that is positive childbirth experience. So till then, probably we have to wait, and we can say that labor care guide definitely is a help at the moment, but it will take some time to remove its bottleneck or to the hesitation which is there. Till then, probably it is a help with hype, but later on this hype will go away and it will become a very useful tool in our labor wards. Thank you very much.
Thank you so much, sir. It was a very, very knowledgeable topic and must topic that everybody should be aware of. I myself, I am a labor room in charge for the time being, and I can see, sir, whatever you have brought up, we have also started using it in our labor ward. However, we have not yet reached to the optimum level, but we will be trying, and let's see if it is helpful for us in future. So then we will be taking our questions at the end of the session. Shall we move ahead, sir, with the next talk?
Yes, yeah. Thank you, Dr. Ashok. That was fantastic. And that is exactly the reason why we gave the LCG guidelines to you, because that's the topic of absolute hotness going on all around. And I'm sure you did a great justice to the particular topic, and there are enough people who will know what to do and how to do about the labor care guide. Yeah, Alka, you can go on to the next speaker introduction.
So having spoken about so much about the first stage or the first stage of labor, so then the most important part is about epidural now, the pain relief during labor. So epidural analgesia, no pain. Right. So I'm very proud of Dr. Akhilandeshwari Madam. She is our professor of Department of Anesthesia and Pain Medicine, Sri Ramchandra Medical College and Research Institute, Chennai. Her areas of interest has been obstetric anesthesia, airway, and pediatric anesthesia. She has written chapters on airway equipments, anesthesia for high-risk pregnancy, and post-LSCS analgesia. Faculty for an airway workshops in state and regional conferences, reviewer for JOACP and Airway Journal. I welcome you, ma'am. Ma'am, you can share your screen, ma'am.
The screen, ma'am?
Yeah, make it slideshow.
Okay.
Yes, ma'am, we can see. Ma'am, make it slideshow, ma'am.
Yes, great.
Good evening, all. I think it's an honor for me to be in this ICOG National Webinar Meet. Thank you, Dr. Pandiyappan, and all my senior obstetric friends. So moving on to labor epidural analgesia. I think this is one of the most debated topics for more than 3 decades, with so much of research and publications talking about the ways to give neuraxial analgesia and how about finding newer drugs to newer drugs and newer methodologies to give the pain relief. Why is this so? If you look, dynamics of labor is very unique, and you cannot make any generalizations with regard to the entire obstetric population. The next is, even for a senior most obstetrician, I think it's very difficult to prospectively predict the duration of labor with regard to the first stage and the second stage of labor. And pain being a subjective sensation, it's highly variable depending on each patient's sensitivity and response to pain. In addition, even ethnic differences occur in the method of how they tolerate the labor epidural pain. So with so many intriguing factors coming into play, what are our goals during providing labor analgesia? This is to provide effective labor analgesia with least effects on the mother and the fetus. So when we look at the options which are available for providing labor analgesia, we have parenteral opioids, we have inhalational analgesia in the form of Entanox, and then neuraxial analgesia and other adjunctive and ancillary non-pharmacological methods. Of all these methods, if you look at it, epidural is the most safe and a reliable method to provide analgesia. Why is this so? Because this can be given not only for any laboring patient, even for a high-risk parturient who's having some cardiac disease, or a patient with a scoliotic disorder or a respiratory disorder who cannot tolerate the stress of labor. I think most often we will be aware that during labor pains, your cardiac output and your uterine transfusion, all these poses an increased margin of decreases the reserve of a patient who's having compromised cardiac function. So by providing labor epidural, we are giving, we are attenuating these stress responses to a major extent, so that the mother enjoys the course of labor with least effects on the fetus. And in addition to that, compared to other modes of analgesia, this has got the minimal placental transfer of drugs. Unlike pethidine or tramadol or your low-dose ketamines or your remifentanil, the incidence of respiratory depression of the mother is quite least with neuraxial analgesia. And in case if there is a need for operative delivery, there is an easy conversion which is possible, because there is always an epidural catheter which has been functioning throughout the epidural during the course of labor, which can be used for anesthesia for a cesarean delivery. And when you consider the maternal satisfaction, it appears to be in the highest range only for neuraxial analgesia. And regarding the stress response to labor pain is also attenuated, which I told you before. Now, when we come to the methods, or what are the options which are going to make this neuraxial analgesia a successful one? The first is the technique, the neuraxial technique which we are going to adopt, whether it is an epidural technique, whether it is a combined spinal epidural technique, or a dural puncture epidural technique. Next, when you think, what is the concentration of the drug which you are going to give, and what is the type of the drug which you are going to give? And the next comes, what is the type of maintenance which you are going to do for maintaining this labor analgesia? This is very important, because unless it is going to be for a variable period of time. So what is the type of maintenance which you are going to give after a bolus determines the success and the outcome of your successful epidural analgesia. When we look, we're going through one by one, we will look what are the factors. In addition to all these things, there should be a shared decision making with the obstetrician at every level when you give the top-up dose, and what is the progress of labor. All these things have to be assessed throughout the labor course, because it is not like all or none phenomenon. Once your epidural is working, it doesn't mean the outcome is going to be always a positive one, because it needs continual monitoring, like a surgical during surgery. Whatever we do, I think it should be continued during labor analgesia also. And what are the, when you look at the techniques which are available, For neuraxial analgesia, as I told you, it's conventional lumbar epidural. The other thing is your combined spinal epidural. Then comes your duropunctal epidural analgesia. And with regard to spinal analgesia, it is not practiced throughout the world as a recommended technique. But where there are low resources for for conducting an epidural anesthesia, people have given spinal low dose spinal alone to decrease the pain relief in the mothers. So when we look at the conventional epidural technique, what is being done is you identify the epidural space using the loss of resistance technique, and then a catheter is placed in your epidural space. And then the drugs are being given so that during the first stage and during the second stage of labor, there is a sensory blockade which decreases the pain. But what is the drawback of this technique is, with an epidural, there is quite often a sacral sparing, because all of us know that the nerves which are supplying the pelvis area is from the conus medullaris, and these are very thick nerves and it is very difficult to block them. And second thing is, epidural can have a septum in them, and when you're giving a very low concentration of local anesthetics, there can be a unilateral block which can happen like during surgical anesthesia. And when you look at the onset time of epidural analgesia, it occurs nearly after 10 to 20 minutes of giving a time giving the epidural bolus dose. But whatever said and done, this is one of the time-tested things, and it is one of the gold standard technique which is being throughout the world. And the next one is your combined spinal epidural. In this combined spinal epidural, what you do is you first find out the epidural space using your cuboid needle, following which through the same needle, you introduce your 27 or 25 gauge spinal needle introduced into it, and then a minimal dose of local anesthetic along with an opioid is injected into the spinal subarachnoid space. And you don't initiate your epidural catheter dosage for the first 45 minutes or till the patient complains of pain. Only then the epidural catheter is activated. Till then, low dose spinal is going to provide analgesia. Why is this technique being promoted? Because it is one of the quick onset of pain relief is achieved with this technique, and sacral sparing never occurs, and unilateral blockade is also not possible with this, because the entire drug gets diffused into your intrathecal space inside the TSF, and there is very little chance of unilateral blockade or failed block segments. All these are not possible. And when we look at the quality of analgesia, it is far superior. And so when do we use this CSC technique? When you want to give rapid analgesia to a mother, for example, someone who's screaming in your labor room, and you know that she's gone into late stages of first stage of labor, or is she in the early second stages, you can provide the CSC technique, because immediate pain relief is going to be there, and it is going to last for 1.5 to 2 hours. So that can you can tide over your second stage of labor pain also with this spinal thing. And in cases where there is an anticipated difficult regional anesthesia, this combined spinal epidural technique is the technique of choice, because once you know that your CSF comes, you know that the epidural catheter is going to be in the epidural space. There is no chance of your misplacement of your epidural catheter, because you're passing your spinal needle through your epidural space, through the same space. That is why wherever there is a anticipated difficult regional, for example, in morbidly obese patients, or in a patient with a scoliotic surgery or a posterior instrumental surgery which is being done, then you go for a CSC technique. And as I already told you, multipara where the progression is going to be very quick, a CSC technique is also very helpful. And in very demanding and distressed patients, this is the first choice. But one of the concern with this CSC technique is it causes fetal bradycardia, and hypotension can be there. It is not that it occurs in every patient, but there can be a transient fetal bradycardia. Why is this so? That is because of your rapid pain relief which it produces, because of which all your catecholamine surge goes away and your beta agonist really comes down. So this can cause uterine hypertonicity, which is one of the reasons for bradycardia, which should be kept in mind whenever a CSE technique is being practiced. So once there is a fetal bradycardia, I think we can do intrauterine resuscitation for an oxygen, give IV fluids, and then give a lateral tilt. It will usually resolve, and this is nothing to worry for few minutes. Only when your bradycardia is very persistent, then you have to worry about a operative delivery. The third thing which is being in practice is your dural puncture epidural. It is similar to your CSE technique, but only difference is here you do not deposit any drug in your subarachnoid space. You just puncture your dura mater so that there is facilitation. The hole is created for facilitating the drug transfer from your epidural space into your subarachnoid space. It is a low, what do you say? It's a passive transfer. It is not an active transfer like your subarachnoid blockade. The advantages of this dural puncture, less incidence of hypotension, there is less pruritus, there is less bradycardia, fetal bradycardia, which occurs with the CSE technique. But the onset of blockade is somewhere intermediate, I would say, whereas in a CSE technique, immediate, whereas in an epidural, it takes 10 minutes. This is something intermediate between your epidural and your CSE technique. And the one more advantage is, just because you're not giving a drug in the subarachnoid space, you are testing your catheter by giving your drug. So once your catheter, when a drug is given through your catheter, you know that your epidural catheter is also working. The next thing which we have to worry is your epidural drug concentration. So initial days, what was being practiced was 0.25% bupivacaine in the early 1970s and 80s. That time, which there was a lot of motor blockade which happened. Then we switched over to 0.125% bupivacaine, and then it became 0.1% bupivacaine along with an opioid. And now the recommended practice is 0.0625% bupivacaine along with an opioid is the current recommended treatment. So when you give these ultra low concentration drugs, there is minimal motor blockade. That is what you mean by a walking epidural. It is not that the patient is made to walk. It just means that there is nil motor blockade and your patient is able to ambulate on her bed very well, and she doesn't feel the numbness or more heaviness in her legs. So with this technique, the maternal satisfaction is also very good because she gets both pain relief and she's able to ambulate. And when you look at the after what is the thing you have to do after a you have to maintain your epidural infusions. What is the method of maintaining which will give you absolute consistent pain relief is what we are aiming for. So when you give manual intermittent bolus dosing, what happens is there are troughs and peaks in your epidural space with regard to your drug concentration. So there are no constant drug levels. So there can be breakthrough pain. And there can be a delay in top-up because it is being manually given. So all these things, to avoid these things, they came up with the idea of after a bolus dose, you continue them with continuous epidural dosing regimen using your infusion pump. What happens with this is there is a constant infusion which is being given irrespective of whether the patient is having pain or not having pain. So, and in addition, what happens is, and the patient has a breakthrough pain, you have to give a intermittent bolus. So when you put them on a continuous infusion, ultimately there is a large volume of drug which is being given, and that can result in motor blockade. And when there is a constant infusion, the spread is also not that wide enough to cause very superior analgesia. So the spread is less, so there is more incidence of breakthrough pain. And when there is more breakthrough pain, you tend to give more boluses. And when there is more boluses which is being given, what happens is the mass of the drug ultimately increases, and then you have motor blockade. This is the one of the disadvantage. The next recommended technique which is currently practiced is programmed intermittent epidural infusions, where instead of manually giving, the pump automatically delivers constant amount of drug in your epidural space. With this, the spread is supposed to be superior because there is a intermittently you're injecting the drug. So when you give something intermittently, what happens is the drug exits from the epidural catheter at a higher injection pressure. So when it exits from the higher injection pressure, the spread is uniform across the epidural field. So there is less wider blockade and breakthrough pain is also less. And the most effective method is when you combine this intermittent epidural stimulus along with the patient-controlled analgesia. So the patient, what happens is, in spite of giving a more constant boluses, if the patient has a breakthrough pain, she has the advantage of pressing the patient-controlled boluses. When she self-administers the dose, the analgesia is supposed to be more better because she's been given it's like a placebo effect, and she feels, yeah, my drug is delivered, so I'm going to get pain relief. There is a positive feedback on the patient. And when you look at the effect of continuous epidural infusion versus intermittent epidural infusion, what is the evidence? Where they have studied both primipara and multipara women. When you look at programmed intermittent epidural infusion, which I was talking to you previously just prior to this slide, the duration of second stage of labor is minimal with PIED, and in addition to that, the blockade is also very minimal because less mass of the less drug is being given to the patient in intermittent epidural boluses. And when you look at what are the outcomes of epidural analgesia on obstetric outcomes, as far as the evidence goes, there is no significant difference in the rate of cesarean delivery in between patients who have got epidural and who have not been on parenteral opioids. And the second stage of labor is definitely there is an increase, but to say it is clinically significant may be more relevant rather than saying statistically significant. When we look at all these studies, they all show that there is no statistically significant difference in the second stage of labor. But when you look in practice, definitely patients who are on epidural infusions, they take a little longer time during the second stage of labor, which we have to admit. And the most important thing is, what is the timing of initiation of epidural analgesia? Is it based on maternal request, or is it at a particular level of cervical dilatation? And what is the effect of this initiation of epidural analgesia, whether it prolongs or duration of
Sorry to interrupt, ma'am. Another 5 minutes, ma'am.
Yeah, so with regard to cocaine review, the rate of operative delivery is similar, and there is minimal increase in instrumentation delivery. And when you this is a study which is there from your obstetric journal. It is a very good study in terms where they have defined, they have divided the patients who have got epidural analgesia into based on the cervical dilatation as 1, 2, 3, 4, and 5, 6, 7, 8, and 10 till full dilatation. And what they found was there was no the timing of epidural analgesia did not affect the instrumentation, or it did not affect the obstetric outcomes. So with so much about evidence, what are the challenges in conducting studies with epidural is you need to do large randomized trials because of the complexity of dynamics of labor. With and without epidural may not be possible because it is very unethical to deny labor analgesia to a patient because he falls into the non-epidural group. The real duration of first stage is difficult to assess, and with that, there cannot be no direct negative causal relationship between analgesia and labor outcomes. But so much so, what are the things we can do? We have to definitely avoid the unintended effects of neuraxial analgesia. It is not always possible to avoid them because anytime the patient can have intravascular injection, there can be subdural spread of your drug instead of epidural. Will result in higher levels of blockade. There can be accidental intrathecal administration of a large volume. So we have to have our labor group equipped with resuscitation equipment and anesthesia physician who will be able to handle all these emergencies. And there should be active involvement of your obstetric physician with regard to assessment of fetal well-being and progress of labor. So when do you counsel for labor analgesia? Definitely it should occur in the antenatal period because whenever the mother is having a pain score of 9 and 10, when you go and talk about labor epidural, she will definitely accept to it without knowing the risk associated with it and what are the expectations. All these have to be told antenatally. For example, the common side effects are itching, shivering, hypotension, mild numbness in the leg, and even an epidural not working comes under one of the common risks associated with epidural analgesia. And with regard to very rare thing, epidural abscess, permanent nerve damage, and temporary nerve damage, these are all very rare. And hematoma and unconsciousness, this is 1 in 1 million, I would say. And with regard to the neonatal concerns with neuraxial analgesia, one of the most controversial thing is about epidural fever. It is being considered as a pro-inflammatory state which occurs secondary to initiation of neuraxial analgesia. They say there is a sterile inflammation which occurs, which releases interleukins, and that is the cause of fever. And it is most often mediated by local anesthetics. And it's very important to remember the incidence of labor epidural fever increases to 36% when the duration of labor is less than 18 hours. This is especially because of the impaired heat loss due to sympathetic blockade following your epidural analgesia. And whenever there is fever in a parturient, we cannot take it lightly as epidural fever because chorioamnionitis can also be coexistent, and it is very important to evaluate and investigate this patient. What is a concern with epidural fever is they can trigger neonatal seizures, they can cause cerebral palsy when it is secondary to chorioamnionitis, and it can also cause transient neonatal encephalopathy. So always, how do we prevent this? You limit your dosage of local anesthetic, use ultra low concentrations and intermittent dosage, and restrict your usage in anticipated cases of prolonged labor and in premature fetus because they are more vulnerable to the effects of fever. And when you look at the incidence of labor epidural with autism, and it has been shown that there is no clear-cut evidence to say that epidural analgesia results in autism. And regarding the consensus statement also reiterates the same. And breastfeeding, only when your fentanyl dosage is more than 200 micrograms, it can interfere with your breastfeeding. And so with this, what are the practice points with regard to neuraxial analgesia? Maternal request for analgesia is an indication for initiating neuraxial analgesia if the patient agrees to it. And use of low concentration of local anesthetics is very essential to avoid motor blockade. Periodic assessments of pain is very essential with regard to the quality of pain and type of pain so that you can address it in a proper way. And anticipate difficult and prolonged labor in patients requiring more frequent top-ups and more number of top-ups, and always titrate to individual patient needs. And there is a possibility of epidural failure, so resiting the catheter should also be done in conjunction with the patient, and it always involves the shared decision making. Thank you.
Thank you, Dr. Akila ma'am. It was indeed a very elaborative talk on epidural analgesia. We'll move ahead to our next speaker because of we are running shortage of time. We'll take the questions at the end of the session. Sir, is it okay? Shall I move ahead?
Yeah, please go ahead, and thank you, Akila. That was wonderful. And please wait on for the questions because I'm sure there'll be questions in the chat box. Sir.
So moving on to our next speaker, we have Dr. Shaijus Nair, who is a chairperson of Midlife Management Committee of FOGSI, a joint secretary of Kerala Federation of Obstetrics and Gynaecologists 2021 to 2024, and a past chairperson of Research Committee of ICOG, president of Kannur ONG Society, Kannur, Kerala, fertility specialist of ARMC IVF Fertility Center, Kannur, and gynec laparoscopic surgeon at Kannur, Wayanad, and Vadakara. He has plenty of awards and recognitions to his name, like SN Joshi Women Empowerment Award 2022, Mrs. Shailaja Pandit Women Empowerment Award 2020, MS Signature Social Reformer Award 2022, DIRA Award 2022, FOGSI International Traveling Fellowship Award 2019, So he has all the above listed awards to his name. I welcome you, sir. And today he'll be enlightening us with routine episiotomy versus restrictive episiotomy. Over to you, sir.
Thank you. Can I share my screen?
Yes, sir.
While Dr. Shaijas is sharing the screen, Shaijas is quite popular on the dance and the singing front also, Alka, and we don't make a mention of it on the CV slide. And apart from all the awards he's got, which is mentioned, I think he should be putting that on the screen of the CV as well. And more important than that, he's always awarded a very nice friend from heart. And so, yeah, Shaijas, your screen is on, and thank you for sharing your screen and being with us.
Thank you. Thank you so much. So nice of you all. I bring greetings from my FOGSI team, Rishikesh sir, Madhuri madam, Yashodhara Pradeep madam, my vice president, and the entire midlife management committee of FOGSI. And I also bring greetings from the little place located at the northern tip of Kerala called Kannur, a vibrant group of almost 130 plus members who are excelling and doing their best, not just on the academic front, but on the social front too. I have a very interesting topic at hand. Before I get started, I would like to thank Rishikesh sir, Lakshmi madam, the chairperson of ICOG. I think your big smile can lit up any day and can add energy to anybody, I feel. And ICOG really required that, and you're doing some great work after taking over from the past office bearers. My thanks to Parag sir for always being supportive throughout this journey in FOGSI, Madhuri madam, Ashok Kumar sir, and Palniyappan sir. Very specific thanks for this topic, because people ask me, do I go in search of out-of-the-box topics, or these topics come in search of me? So I always say that it's probably because of people who believe in me and who probably trust and give such topics which are slightly offbeat. And I try my best to do a little bit of justice to that. And I hope I can do that today also. Routine episiotomy versus restrictive episiotomy. It rhymes well, but if you're not very comfortable with the word restrictive, maybe you can use a word called selective. That is the other option that you have. Now, this has been a topic which has been debated from times immemorial. And we all would understand and agree that there are a lot of stakeholders when this topic comes into the picture. Primarily, we look at the clinician as well as the pregnant mother and her perineum. But with a lot of feminism coming into the picture, there are a lot of organizations which talk about women's rights these days. And very importantly, they need to do that. And here is probably a choice that a woman can make, whether she needs to get subjected to a procedure like an episiotomy as a routine, or whether she needs to be given a choice. So since there are a lot of stakeholders, and that's why this topic could become interesting any day. Why are we concerned? We understand that a normal vaginal birth can cause tears in the vagina as well as the tissues around. And sometimes these tears can definitely extend to the rectum also. We all understand that these can be repaired surgically, but it does take time to heal. To avoid these tears, what do? We perform an episiotomy. And episiotomy is meant to prevent any significant tears and thereby facilitate vaginal birth. On the other hand, if you look at it, both a perineal tear as well as an episiotomy would require a suture. Both can result in severe pain, bleeding, infection, and maybe painful sex. Both can contribute to long-term urinary incontinence. So if you look at it from both sides, I would definitely want all of you to think about this particular tagline. Then why cut all to prevent tears in a few? Now, this is the thought that we are going to build on and probably have an answer by the end of the discussion in another 15 minutes time. So why cut all to prevent tears in a few? Now, a definition and classification of perineal tears is something which I need not teach to such a learned audience. First degree, second degree tears, we all know. But I want to introduce this term called severe perineal trauma, which primarily refers to a 3rd degree or a 4th degree tear. And an episiotomy is primarily intended to prevent a severe perineal trauma. Now, there is a little bit of history behind an episiotomy. We understand that it's a surgical incision on the vagina and the perineum. And the first documented episiotomy dates back to close to 270 years ago. That's pretty long back. And then if you look at that entire history and how the rates of episiotomy 20th century onwards, primarily because more women started delivering at hospitals. Now, on a lighter vein, it is generally said that all those women who could deliver before the obstetrician reached the hospital delivered vaginally, and the others underwent a cesarean section. So just like that, because we had this cut all policy, unfortunately or fortunately, episiotomy has become one of the most commonly performed, or if not the most commonly performed surgical procedure in the world. And we need to rethink. If you look at the episiotomy rates and certain facts regarding that, reported rates of episiotomy would definitely vary. It could be as low as almost 9.7% if you look at the Sweden data, to almost 100% in Taiwan. And as I already mentioned, there are a lot of stakeholders. Clinicians' perspective is very important. How aware are our women regarding this entity called an episiotomy? Are they being given a choice? Should they be given a choice? And these are questions which we will have to answer. And then probably we need to create policies regarding an episiotomy also. So, and that is when we come to a consensus and an answer on whether we need to cut all or not. Episiotomy rates are very high in countries like Argentina and China, where there is a policy of a routine episiotomy when compared to the other countries where they use a selective one. Now, this is an important question. How can we actually do a selective episiotomy or a restrictive episiotomy? Here, a clinician would use his or her clinical judgment to determine the need for an episiotomy. And they are primarily in situations where the benefits seem to outweigh the risk, because we are living in the years of evidence-based medicine, and we need to look at these two entities called benefits and risk, and we need to balance them. Now, impending severe perineal tear, which people are able to judge well because of their clinical acumen and their experience, when there is a prolonged second stage labor and you want to hasten it, shoulder dystocia, instrumental deliveries, non-reassuring fetal heart, where you're attempting to expedite the delivery process, and that's where you would actually use it. In US, the episiotomy rates, if you look at, they have significantly reduced from almost 60% in the 1979 to almost 24-25% by the time it reached 2004. So that's been a dramatic decrease. In Finland, the episiotomy rates have similarly come down from 70 to 50 in a 10-year span time from 1997 to 2007 in primigravida. And if you look at multigravida, from 20 to almost 10%. So entire world has been probably getting more selective with the use of episiotomies, is what this trend would tell you. Now, this is something which we have been hearing for years together. From the time we had our first labor room posting when we were a postgraduate, when we were finally a medical undergraduates, we were posted in labor room, and we have been hearing this, isn't it? Less trauma to the baby, improved UPGAR scores if you perform a routine episiotomy, fewer ICU admissions because you're creating more space for the baby to come out, and some short-term outcomes, less pain, less bleeding, less infection, less dyspareunia, and it's going to be a surgical cut, so that's going to heal better. And if you look at the long-term outcomes, less trauma overall, less dyspareunia, less fecal incontinence. So we have been presented with such big data and facts. And that is why we were religiously cutting every perineum that came in front of us. Okay, but times have changed, and so does the thought of looking at evidence to really believe whether these facts are right or not. And on a lighter vein, if I just look back at my own undergraduate days and my labor room posting and all that, and what has been presented to me at that point of time with whatever evidence or whatever assumptions people had, I always had this doubt. Did we cut all to create an opportunity for us to suture, because we were learning to suture also, isn't it? So only if you cut, you get an opportunity to suture. And I think at that point of time, suturing in episiotomy gave us a lot of adrenaline surge, just like what I would get today if I perform a radical hysterectomy, isn't it? So that's a food for thought. Now, does evidence support these assumptions which we have been told by our teachers or by our seniors or by our own colleagues? Almost 12 trials, if you look at evidence. So what does it tell you? It tells you that in women in whom an unassisted vaginal birth was intended, it was a selective episiotomy that has resulted in less severe perineal trauma. And it was a selective episiotomy which could reduce the number of those severe perineal tears. Now, selective versus a routine episiotomy seem to have little or no effect on an UPGAR score of less than 7 at 5 minutes, no effect on blood loss at delivery, dyspareunia, urinary incontinence, genital prolapse. All these were shown to be benefits of an episiotomy when compared to a perineal tear. But evidence is telling us today that there's basically no difference. There's no clear evidence of using an episiotomy in a primigravida, not using a routine episiotomy in a multigravida really does not make a difference as far as the evidence is concerned. And no difference either between the techniques to the midline or the mediolateral, about which we have been talking and we used to so enthusiastically and passionately talk during our undergraduate and early postgraduate days. Now look at some evidence from the Cochrane Library 2017. They talk the same, isn't it? When no instrumental delivery is planned, it was a selective episiotomy policy that resulted in fewer women ending up in a severe perineal and vaginal trauma, and you need not actually cut all. If you look at this FIGO statement, it talks about restrictive rather than routine use of episiotomy that need to be exercised due to potential short and long-term complications associated with an episiotomy. So episiotomy doesn't look that good when compared to how it was projected in the earlier days. The Egyptian study where they talk about safety of a selective episiotomy, which concluded that the incidence of perineal tears and obstetrical anal sphincter injuries, what we call as OASIS, there's absolutely no difference whether you cut all or you selectively cut. So that's again a food for thought for us. Now, whenever we talk about any evidence related to childbirth, I think it should be the Indians and the Chinese who should be talking, because there are more number of deliveries in these two countries when compared to anybody in the world. So look at some Chinese study, a recent one from the BMC Pregnancy and Childbirth. You will get to know that it is again in favor of a selective episiotomy being safe and can be definitely recommended over a routine episiotomy in obstetric and tertiary care centers wherever the delivery happens as far as China is concerned. Now, this is an Indian study from the Baroda Medical College done by Deepthi et al. And that again talks about a selective use of episiotomy, improving maternal outcome by reducing perineal lacerations, and those having an intact perineum having the best outcome when episiotomy is given selectively. Now, so what are the take-home messages before we end? I hope I've not confused you much. Again, proponents of a routine episiotomy or a episiotomy for all would argue that a routine episiotomy would facilitate delivery, surgical healing would be better, reduces 3rd and 4th degree tears, but the evidence really does not support that. Talking about a 3rd degree and a 4th degree primarily, those are the ones where it would actually make a difference if we use it selectively. Now, there are no clear differences when you look at the other factors: blood loss at delivery, babies with a newborn UPGAR, a score of less than 7 at 5 minutes, perineal infection, women with moderate or severe pain, long-term dyspareunia, long-term urinary incontinence when compared to a policy of a selective episiotomy. If you look at the hospital stay, you would practically think that a woman with an episiotomy might stay maybe for an extra day while her episiotomy heals. And if she has an intact perineum, then she might leave home more quickly, right? Possible, because we are thinking in terms of where there is an insurance claim for most of these women who undergo delivery or any procedure for that matter, and you are intending to make it more convenient, reducing the hospital cost and the hospital stay. So we are concerned about all these things these days. Fine. So before I finish, I want you to all put your thinking caps on. If this is what the evidence tell you, then why cut all for preventing tears in a few, and that too with just an assumption and not at all substantiated by evidence? So time to rethink. So if you happen to agree with me, I think it's time to say thank you and let's dance, because these days they say anybody can dance, and that's good for your health. And I hope I've been able to put across the point and make this out of the box topic relatively interesting. With that hope, thank you so much for giving me such an opportunity. And it's always a pleasure to talk in an ICOG masterclass with all the stalwarts around. Thank you so much, everyone.
Thank you so much, sir. That was indeed very interesting and food for thought. So we shall think on it, sir, and probably we can have more questions coming up in our chat box for our first 3 speakers. So would you like me to go ahead or just wait for some questions to come?
I think there is one question here. Dr. Akila, what are your drugs of choice for epidural labor analgesia? I thought you had mentioned it enough and more on that. Dr. Akila, is she here?
Yeah.
Yes, Akila, would you want to tell that before questions come? And Shaidas, that was excellent. Thank you very much. And it was awesome. And as usual, so we know why we call you again and again for ICOG Masterclass. And thank you very much. Yeah, Akila.
Our choice is always 0.06 to 5% bupropion with fentanyl 2 micrograms. Okay, that is what we give routinely.
Dr. Lakshmi, there are no questions.
Yeah, I think Shaijus, we all are dancing with you. And why cut all to prevent tears in few? But we can prevent tears because you know that this is inadequate or this patient needs selective episiotomy, what you taught us. So, I mean, really we can prevent those tears also. So I will say, let's be selective. Yes, so I think everyone is agreed with you, Shaijus.
Thank you, madam. Thank you.
And I think for Ashok, he has cleared everything about those labor care guides. So I can't see any question for Ashok. Ashok, you want to give any clear, you want to say anything? Then Dr. Akila, there was one question, I think she answered while I was on phone. So Palani, your comments on first session, and in the meantime, Parikshit, I think he has logged in. We will have his talk. I will call him. Yeah.
No, there's nothing for me to
comment. Logged in, yeah.
Yeah, and it was, I'm sure all the 3 speakers were extremely good and extremely informative, and we could get clear-cut messages on to the participants and the delegates.
Dr. Maithili Tang, inko co-host banao, Dr. Tanko.
Yeah. Dr. Ashish Mukhapadhyay couldn't join us for very obvious reasons, and so we have Dr. Lakshmi has made last-minute arrangements to have Dr. Parikshit. Hi, Parikshit.
I am grateful to Parikshit. He agreed to join at the last moment, make him co-host, and he said, "Yeah, madam, I will give talk on forceps. I know he's a hardcore obstetrician." So he pitched in at the last moment. Thank you from bottom of my heart, and also on behalf of ICOG, Parikshit.
Just like how we do emergent sections, the session was emergent delivery by Dr. Parikshit. Yeah, Parikshit. Alka, you can go ahead.
The most benign looking hardcore obstetrician, I would say.
In between Shaijus, in between egg pickups and cesarean sections, I in to teach everyone about the forceps.
No, I really feel this is, I mean, sorry, please go on with the rest of it. I just wanted to say that, you know, every time there's a cancellation, I hope it's not a forceps which gets cancelled, because postgraduates are getting less and less exposure, you know, to this instrument. And if unfortunately teachers have to cancel, let it not be this. So I wanted to really save this session.
Yes, thank you. Yes, Akila, please.
Alka, go on.
Yes, Alka, please introduce.
Yes, yes, ma'am. So I'm very glad to introduce our Dr. Parikshit. Thanks, sir. He is actually a consultant in Ashwini Maternity and Surgical Hospital, Center for Endoscopy and Assisted Reproduction, Mumbai, consultant in Jupiter Hospital, Thane, honorary professor in Pacific Medical College, Udaipur, consultant for assisted reproduction at 16 centers. He is a treasurer of FOGSI.
It's okay. Don't read everything. It's all right.
Okay, I'm welcome you, sir. Thank you so much for joining us in our last minute. And he'll be speaking on forceps, a necessary tool or a telltale. Over to you, sir.
Thank you, Alka. And my thanks to Dr. Lakshmi Shikhande for involving me in today's session. Please excuse me if you don't see Ashish, it's not my fault. This will stop other people. Okay, so answer is yes. And now I'm going to start sharing my screen. Hope that's visible.
Yeah.
And I'm putting it on screen show.
Yes.
So as I said, the moment ma'am said that, you have to take a talk on forceps, I immediately agreed, even though it was a bit last minute. And, the subtitle is a little different, but yet I feel that forceps is something which we cannot let it become a forgotten art, because I strongly believe that it's an essential skill. So the question that we first need to ask ourselves is, why is the forceps an essential skill? Because it has an established place in obstetric practice. This is something that has been happening in the science, in the world since centuries, literally. And it's a very well accepted mode of conducting a delivery. Now, if you think that, okay, let's get rid of all instrumental deliveries, and especially let's get rid of forceps, what are you going to do? You're going to do a lot of cesareans at full dilatation and very low stations. And those can be difficult and potentially complicated. Of course, all of us are worried and concerned about C-section rates and what best we can do to safely keep them in check. And sometimes an instrumental delivery, and especially a forceps, can be achieved very quickly when time is of an essence. And therefore, I strongly believe that forceps is an essential skill. So in that sense, if it's so very important to us, why are we forgetting this art? What's happening? That's because moms, and I would say couples, are more and more worried that there's going to be an injury to the child. And inevitably, they've always heard some kind of a story, where something went wrong with some child, and the only thing that could have been identified is that that child was born by a forceps. Of course, we know that it's not a contributory factor at all, but it is made into a causative factor by our colleagues. Those are pediatricians, child neurologists, psychiatrists, and it's unfortunate that the instrumental delivery, especially the forceps, gets the blame for a lot of unnecessary things. There are medico-legal concerns that, if you do a forceps and something happens, you will be blamed for not doing a cesarean. But remember one thing, if the result is bad, then you will get the blame. If the result is good, you will get praise. So the mode of delivery does not really matter. We are forgetting this art also because cesarean deliveries are today safer than ever before in the history of mankind. And the falling rates of forceps use, especially forceps use, is much more in modern obstetricians as compared to people who have graduated maybe 30 years ago. And a large contributor to this problem is that training in the art of forceps application is on the decline. All these have contributed to less and less people doing it, less and less people talking about it, and this getting into something like an endangered species. So if you look at it, it's a cycle. I mean, we are forgetting this art because we are worried, we are fearful. And that leads to avoidance. The moment you're scared about something, you'll not do it. Even if you do it, you'll not do it with all your heart and with confidence. The moment you start avoiding something, you start getting de-skilled. Your level of expertise goes down. And then suddenly one day when you have to do it, you're more likely to land up with an undesirable outcome. What does that undesirable outcome do? It fuels your fear and your paranoia that the next time I'm definitely not going to do it. And this becomes a vicious circle. And consequently, the rates of instrumental delivery and especially the rates of people who are using the forceps effectively has gone down tremendously. This is not only an Indian phenomenon. It's something which is happening across the globe, everywhere. And this is something really to be concerned about. I always say, non vi sedarth, that is not with force, but with skill, we have to achieve what we have to achieve in terms of extracting this baby from the maternal pelvis. So where do we go from here if we want to promote instrumental deliveries and especially if we want to promote forceps deliveries? You have to become fearless. That means not careless. You have to care, but don't become fearful and let that cloud your judgment. That will happen when you practice by protocol and when you institute medical and medico-legal safeguards. That's what is going to give you the confidence. It's going to give you that cushion of comfort, which will allow you to become fearless, means less fear. And the second thing, what we need going forward is training. The previous generation, that's all of us and a lot of senior people I hear today, learned on the job. That means there are 10 deliveries today, 3 will be normal deliveries, 4 will be ventus, 3 will be forceps. And the little senior obstetricians, what in Mumbai we used to call them lecturers, I think they are also called tutors in some places, would be around to give a hand to the young trainees. Now that does not always happen. So we need simulators, we need mentors who will guide you through when you are having this situation. And you need workshops or training programs like this one, where you can pick up certain skills and then you learn and practice them. So if we go by what I just mentioned, what does it mean when we say practice by protocol? You have to establish an indication and rule out contraindications. What are the medical safeguards that you should have in place? And here I want to give you the concept of a trial instrumental vaginal delivery. Choose the right instrument, avoid the common pitfalls, and understand one relatively unattended concept, and that is parallelism. I'll just talk about it in a little more detail in maybe 5 minutes. And then, of course, you have your medical legal safeguards. That means this woman has been adequately counseled. She's attended antenatal classes or sessions where she's been told that, well, this is a possibility of one of the ways in which a woman may deliver. You take the consent and you document why you did it, how you did it, what happened at the time of the forceps delivery. So this is what I mean when we talk about practicing by protocols and medical as well as medical legal safeguards. Now, when it comes to indications, an old concept was that the baby's head needs to be protected. And this protected delivery was promoted by an obstetrician called Dilly, Joseph Bolivar Dilly from Chicago. Today, this cannot be justified as a standard indication, except where you want to either minimize maternal exhaustion in heart disease, preeclampsia, neurological disease, or anemia, or you want to protect the small baby's fetal head. So you have a preterm or a growth restricted baby, you want to protect the head, fine. You may think about limiting the second stage and preventing a very prolonged smashing of the fetal head on the pelvic floor. Prolonged second stage, in a nullipara, you call it 2 hours without regional, or 3 hours with regional, multi 1 hour and 2 hours. But today this concept is changing a lot. I mean, one of the American guidelines mentions that there's nothing like a prolonged second stage if you're seeing progress all the time. So it doesn't matter how much time has happened since full dilatation. Maternal exhaustion is a subjective evaluation. The obstetrician thinks that, okay, there is exhaustion, and so you go ahead. Abnormal fetal status, either because of meconium, abnormal heart rate pattern. If the center does scalp pHs, then low pH or a cord prolapse. And then there are certain situations which are special and meant for forceps only. That is mid-cavity rotation after coming head and forceps at cesarean. I'm going to completely leave the part about special situations alone today, because there's enough material to speak about the standard stuff. Now, if you look at the current status of indications, purely prophylactic is probably not justifiable. And the standard indication of expediting delivery for maternal or fetal well-being is what has stood the test of time. The indication influences the choice of instrument only in terms of avoiding the ventouse. If it's too preterm, that's where the forceps takes over the ventouse. Otherwise, it's really not a debate. They are complementary instruments which the obstetrician should be familiar with in all situations, with both of them. Contraindications. Now, if there's a definite cephalopelvic disproportion, fetal malpresentation, a high station, cervix not fully dilated, or fetal disorders of structure or coagulation, then you're not going to do an instrumental delivery. You're not going to do a forceps either. Now, where do you draw the line? When we say that, okay, the station is high, where do you draw the line? Today, nobody in the world practices a high instrumentation. That means high forceps is completely out. You cannot justify this in the modern time. Most of us have probably moved the line a little lower. I mean, people are shying away from mid-cavity forceps and mid-cavity instrumentations also, which is all right. But I mean, if it's a skill that you have, please do continue practicing and passing it on, because the mid-cavity forceps is in skilled hands. Please, I would like to emphasize that again. In skilled and trained hands is a wonderful way of relieving certain intractable obstetric situations and avoiding very difficult C-sections and the like. So outlet and low is not really a controversy at all. We should all be familiar and be able to do an outlet and a low operative vaginal delivery and apply the forceps at that stage. Should there be a trial of instrumental vaginal delivery? So what is a trial? It's an attempt at a forceps delivery undertaken with the knowledge that there may be some degree of disproportion which may make the delivery incompatible, especially if you're looking at a low or a mid-cavity application. And there should be a shift in the attitude that comes from the willingness to abandon your attempt at the earliest sign of difficulty. So you do it under spinal anesthesia in the operation theater with the trolley laid out for a cesarean section. So you make an application, you see how it's going. If you feel that no, it's not working, just remove the forceps. Don't give the episiotomy before you are very confident, and shift to an abdominal delivery. This should not take more than 10 minutes to achieve. So if you're able to do that, that's a good trial of instrumental delivery. But the bottom line really is to know when to stop. In my practice, think of every instrumental vaginal delivery as a trial of instrumental vaginal delivery. It's always better to be over prepared. Even after you've done 1000 forceps deliveries, number 1001 can still trick you. So don't get, don't get completely chilled out. Be over prepared. What's going to happen? You'll waste one cesarean section trolley. That's all right. That's not much of a loss. When you look at functions of an instrument, the forceps and the vacuum, the forceps can exert a stronger traction and it can give you compression, which the compression the ventouse cannot give you. But the ventouse can give you auto rotation, which has to be manually done with a forceps application. Where I like the forceps over a ventouse is the correction of asynclitism, and the concept of parallelism is something which I would like to emphasize. Dr. Beniwale is going to talk about the ventouse, and this is certainly not a debate about forceps versus ventouse. But if you do a comparison, you're more likely to fail with a ventouse than a forceps. But a forceps is more likely to be associated with maternal, perineal, and vaginal trauma. So everything has some pros, some cons. You have to use the appropriate instrument in the appropriate setting. So I'm just going to show you this concept of synclitism and asynclitism. This is a fetus who is in labor with a cephalic presentation. I hope the voice is clear. As labor progresses, there is going to be descent.
थोड़ा volume और चाहिए परीक्षित.
Here it is depicted. I'll just up the volume in my system. Oh, it's maximum.
Yeah, you can give commentary.
Okay, then I'll take over and give commentary.
Yeah, you give commentary because that voice is not clear also here.
Okay. So here I'm just introducing this concept of synclitism and asynclitism. This is a fetus who's in labor with a cephalic presentation. And as labor progresses, the baby is going to come down with descent and promotion of flexion. Now the sagittal suture is never exactly in the midline. If that were to happen, that is synclitism. But in real life, that rarely happens. It's either anterior or posterior. And accordingly, you name it asynclitism, which is anterior or posterior. And this is a natural compensatory mechanism because the fetus is not a circle and neither is the pelvis. The asynclitism helps the baby to navigate the pelvis. And that wriggle is important, especially when you have a little bit of deflection, when you have a little bit of a big baby situation. So what does a parallel forceps do in terms of correcting asynclitism? Now, this is a situation where the occiput is between LOT and LOA, and you're applying this parallel forceps blade. You can see that the sagittal suture is more posterior than anterior. This is the midline. This is more posterior. You lock the blades and this accommodates the, look at this. Look at how the blades have locked. Can you see one blade is ahead, one blade is behind. And that is what corrects your deflection and asynclitism. As you pull this baby out, the forceps blade will come into the same parallel plane, and this parallelism corrects the asynclitism without causing trauma to the pelvis or the baby. So this is a concept which I'm just going to demonstrate a video which I had made. This is a typical situation, preemie, post dates, induced with prostaglandins, epidural, full dilatation for a couple of hours. She's been feeling the urge and been pushing since 45 minutes and she's exhausted. So first, what you do is paint the parts, assessment to rule out contraindications. Now, some small tips. Get the thighs hyperflexed on the abdomen, and that opens up the pelvis a little bit. introduce the left blade onto the left side. You're handling the blade very, very gently. You're not turning the handle, you're moving the blade. And the blade is held in place by your assistant. The right blade is now introduced into the right side of the pelvis. This is obviously a parallel forceps, which I am doing. Ensure that there is a lock. Up till now, I have not given an episiotomy. I'm making sure that there is a lock, applying a bit of traction, giving a trial pull and seeing that there is a good descent. Then I tell the assistant to hold the blades up and I give an episiotomy. I know Shai just spoke about giving episiotomies only where it's needed, but this would be a situation where it's needed because there's instrumentation and the size of the baby is a little larger than what is going to safely come out without causing a tear. So you give an adequate mediolateral episiotomy. And then once you're happy with the size of your episiotomy, you go back into traction mode. Give some support, hold the perineum. And the traction is along the curve of Keras. So remember how the pelvis is built, and you do small rotatory and rocking movements and get the baby's head out. Now this baby has come out face to pubes. Frankly, I didn't know that it's going to come out face to pubes. I had misjudged, but because parallelism was there, it was fine and baby's fine. You can see a little bit of meconium stain on the baby's thigh. Everything turned out okay. Mom was fine, baby was fine. So some of the medical legal concerns is consent mandatory. So any medical procedure, they say you have to take a written informed consent, but you could argue that, instrument delivery is potentially life-saving. And then because there was no time, the opportunity was not there and you were acting in the best interest of mother and baby, you did it. But I think it makes sense to take a written informed consent. Always document what you've done. And this is a checklist of what should go into your note of an instrumental delivery, especially a forceps. If you have this in place, you're not only checking yourself, but you're also creating a good medical legal ground in case something doesn't go as expected. So thank you all for your kind attention. And again, thanks to Dr. Srikhande for the invitation. I must thank my friend, Dr. Beniwale, for allowing me to take his slot and jumping in. I'm very sorry, sir, but it was all last minute. So I hope you'll excuse me.
Fabulous presentation, but it was worth it.
Yeah, your passion for forceps, Parikshit, was palpable throughout your talk. That is why I just remembered you have that presentation. And if time permits, you will definitely log in. Thank you so much.
Thank you, ma'am. Thank you.
Thank you so much, sir. It was indeed a very interesting session to watch for. I myself have learned so many important tips when you are applying a forceps. I'll definitely remember all your tips.
Palani,
So moving ahead to our
just a minute. If there are any
speaker.
questions, we can take for Dr. Parikshit because he is
Sure,
having
sure.
a section at 6 o'clock. Otherwise, we
Sure.
will excuse him with profuse thanks once again from ICOG and from my personal thing. Thank you.
There are no questions as such. There are a lot of comments for and against the forceps, but then I thought Parikshit did that debate by himself, and I'm sure he put that message very clearly. And there are a few people who still not agreed to apply a forceps, and still I would go with Parikshit and say we would apply a forceps whenever it's required, and we will master the skill and art of it. And thank you, Parikshit. That was fantastic, and I'm sure you have to go. And thank you very much for logging in at the last minute.
Thank you.
My pleasure. Thank you.
So moving ahead to our next speaker, the topic for the day will be Venture's Most Needed, and it will be delivered by Dr. Parag Biniwale, sir. He is a senior consultant in OBGYN Pune, a postgraduate teacher and unit head in Kamala Nehru Hospital, vice chairperson ICOG 2021 to 2023.
Thank you, Alka. Alka, thank you so much. Don't waste time.
Thank you so much, sir. So over to you, sir.
Yeah, thank you. Right. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be participating in this program today. Thank you, Dr. Lakshmi, for having me here, and thank you, Palni, for the invitation. In the next 15 minutes, I'm going to talk about the other aspect of instrumental vaginal delivery, and that is ventouse or vacuum, which is most needed. Incidentally, vacuum was described almost over 300 years ago, but it gained in popularity in the 70s and in the 90s. In fact, there were so many advances in the delivery of assisted with vacuum that in the United States, vacuum overtook forceps deliveries as when assisted vaginal birth was contemplated. Over the years, in last 60, 70 years, initially there was a certain rise in assisted vaginal births, but later on, consistently, we have a assisted vaginal birth rate of about 10 to 12%. And by the year 2000, 66% of operative vaginal deliveries were performed by using a vacuum extractor. The ACOG classified vacuum extraction way back in 1994, and it was revised in the year 2000, and all of us are still using the same classification, which includes an outlet vacuum operation and low vacuum operations. Now, these are the ones which all of us are routinely performing. It also describes vacuum-assisted cesarean delivery, and let me tell you that whenever you're dealing with a floating head, vacuum works wonderfully well when we are delivering the head, which is high floating. And of course, like Parikshit said, high vacuum operations are a no-no in modern obstetrics. So when we talk about ventouse, we are going to talk about consent, who should do it, when to do it and when not to do it, how to do it, and the problems associated with the procedure. An informed consent is a must. Let's not forget that we are living in an era of medical legality, and especially whenever we are thinking of assisted vaginal delivery, an informed consent is a must. Explanation of the procedure should be given. I can understand that there may not be enough time for us to explain, but we have to tell the patient and the relatives the need, why we want to apply vacuum, and then take an appropriate consent. If time permits, we should talk about risks and benefits. We should also tell them that there are alternative modalities of treatment, which may even include a C-section. And if time permits, we should give them an opportunity to ask questions. So when we think of consent, an emergent or abbreviated bedside consent process still requires the following, and this is something which all of us must remember: a brief description of the proposed procedure to the mother and the family, and a review of indication for the proposed procedure as to why we are doing it. The obstetrician has to be prepared, and when I say a prepared obstetrician, it means that he or she should have the knowledge of the instrument chosen, indications for vacuum extraction, and it should be a well-practiced and appropriate technique. An analysis of the course of labor, which will be a good pointer before we decide the mode of delivery. Pelvic examination is important, and it should determine the fetal position and station. A careful consideration of the fetal and pelvic relationship should be done. And most importantly, the accoucher must be prepared to reconsider or abandon any procedure which proves difficult. So no stunts. Look at the safety of the baby and the mother, and there should be a backup plan of C-section if we fail to deliver the baby by using vacuum extractor. The patient has to be well prepared. So after taking informed consent, do a good clinical examination, ensure that the cervix is fully dilated and effaced, the fetal head is engaged, membrane should be ruptured, and fetopelvic disproportion is ruled out. The bladder should be emptied either by spontaneous voiding or by catheterization if required. Coming to analgesia or anesthesia, we had we've heard an excellent talk on this. Please make sure that the patient is comfortable. So offer her whatever she wants, whatever you can. You can think of a regional anesthesia like a pudendal block. We personally prefer epidural lumbar analgesia for most of these procedures. Coming to the indications, first and foremost, the prolonged second stage of labor. All of us are aware about the new definitions of the second stage, and we must adhere to them before hastening any procedure of assisted vaginal delivery. In certain situations where we need to shorten the second stage of labor, where the mother may also be exhausted, and we may have to cut short the second stage in order to help the mother out. Suspicion of immediate or potential fetal compromise. So if we are dealing with a baby who's possibly jeopardized, or if there is an acutely non-reassuring fetal monitoring tracing, we should think of expediting the delivery by applying a vacuum extractor. But we should also know when not to use. So if you're not trained to use a vacuum, or if you are not confident, don't use it. Please ensure that there is correct application. So an inadequate trial of labor or a lack of standard indication is something which we should keep in mind. If you are suspecting fetopelvic disproportion, if you are not sure about the fetal position or station, or in case of an inappropriate fetal presentation, which could be a brow, face, or even breech, very rarely in situations where there could be suspected fetal bleeding diathesis or demineralizing bone disease, ventouse application is not required. In premature babies who are less than 34 weeks, we would certainly avoid vacuum and prefer a forceps. And we have to be very, very careful when we are dealing with a woman who has failed forceps. We will definitely not use it. And in cases of suspected or known fetal macrosomia, we really have to be very, very careful before using it. All of us have seen the equipment which has a cup, a pump, and a suction gauge. Of course, there are modern devices which are much better. And when we talk about the vacuum extractors, many of us were trained in an era of metal cups, but it is the soft cups which are in vogue. The metal cups typically are a mushroom-shaped device with a centrally attached chain. But what is more commonly used are different type of soft cups, which are either disposable or they are reusable. Traditionally, soft cups are of bell-shaped or funnel-shaped, so we need to choose a particular size of the device depending on the possible birth weight of the baby. And these are the options that we have, including a very sophisticated kiwi cup, which facilitates deliveries really very well. So as we begin the procedure, it is important to do something called ghosting, where we have to hold a vacuum cup in front of the perineum in the same angle and position expected once the extractor has correctly been applied to the fetal head. And then in our mind, we should be prepared to conduct the delivery as smooth as possible. How do we insert the cup? Of course, when we were using rigid cups, we were turning it sideways. The labia were gently spread and the device was slipped in the vagina, while the soft cup, in fact, is partially collapsed by the operator's hand and introduced through the labia and applied to the fetal head. So this is how we apply the Malmstrom cups. And correct application is extremely important. So we always talk about a flexion point, which is about 2 to 3 centimeters before the ahead of the posterior fontanelle in the midline, which definitely helps maintaining the flexion of the fetal head and facilitate smooth delivery. But sometimes the application may be a little difficult, and we may end up doing any of these applications, which of course, where vaginal delivery is possible, but at times becomes a little difficult, and one may have to struggle while delivering a baby with these applications. when we start applying traction, we have to pull perpendicularly and not tangentially. Please ensure that the cord never crosses the circumference of the cup. So this will prevent a pop-off. Never do a zigzag movement, because then you're likely to injure the scalp, the vagina, or even the vacuum may even slip. And the pull should be along with the pain. So whenever the patient is bearing down, use the vacuum pull, and then should be useful in the descent and outlet phase. And this is how we apply traction. So it is essentially downwards, then forwards, and eventually upwards in order to facilitate delivery. And this is typically how a vacuum delivery would look in a nutshell. When we compare the soft cups and the metal cups, we know that soft cups are more commonly used these days, but they have a higher incidence of failure, whereas metal cups theoretically had more chances of trauma to the fetus, and they were very, very useful, especially for occipito-posterior positions. There was a time when we always thought of a stepwise negative application where the pressure was gradually increased, but nowadays even rapid increase in pressure is acceptable. It doesn't matter whatever the device that you're using, do it carefully and do whatever best you can to deliver the baby rather safely. There are some problems which can crop up when you're thinking of a vacuum delivery, and which could include a failure of the procedure and injury. So we should analyze why that vacuum cup slips. It could be because of the faulty equipment or leaking equipment. Secondly, if you're using excessive traction force, please understand that possibly you're dealing with an unrecognized cephalopelvic disproportion or an occipito-posterior position, or if the fetal head is deflex. But here it could be so that you are applying at a higher level, and one has to be really careful while doing it. If there is improper angle of traction, which may cause shearing or impingement of soft tissue, maternal tissue at the introitus, the vacuum can slip. And we must remember the rule of 3. So 3 pulls over 3 contraction if there is no progress, or 3 pop-offs, and after 1 pop-off, reassess carefully before reapplying. And after 30 minutes of application, if there is no progress, we declare that the vacuum extraction has failed, and then we can think of an alternative method. And when we think of an alternative method, the literature says that use of sequential instruments is not recommended. So vacuum delivery failed. Forceps delivery is something not acceptable. So maybe C-section would be a safer alternative in case of a failed ventouse delivery. The maternal complications are something which we must keep in mind. So we may be facing challenges like lacerations, but let's not forget the higher incidence of urinary retention or urinary incontinence in these women, and the anal incontinence and levator avulsion is much more common in women with history of forceps delivery rather than vacuum-assisted delivery. We always believe that if we are using a soft cup, we are not harming the baby, but please remember that fetal complications are known to be more in case of vacuum extractor. Subgaleal hematoma, though not a very, very common occurrence, but it is a serious neonatal complication seen in about 1 to 3.8%. And these are the babies who will have a boggy scalp, swelling crossing the suture line, expanding the head circumference. So other injuries like cephalhematoma are also known, and it could be as high as 6%. The literature says about 1 to 26% of vacuum deliveries may land up with cephalhematoma. So this is something which we really have to be very, very careful about. Intracranial hemorrhage and retinal hemorrhage are also described in the literature. So let's not presume that vacuum is the device which is free of complications. So you should be aware of possible complications of vacuum extraction before we use it. But it is important that we avoid these complications. So we must confirm indication and conditions and then take a decision about vacuum extraction. Proper anatomical placement is extremely important. We must avoid entrapment of maternal tissues. Correct angle of traction is extremely important so that we avoid excessive force. We must coordinate traction with maternal efforts, and then we can certainly control the descent and expulsion. And let's not forget the rule of 3. And then if you feel that the delivery is not happening, stop the procedure. Can we reduce vacuum extractions? Possibly, yes, by involving a one-to-one birth attendant, monitoring of the progress of labor by partograms. And we've heard Dr. Ashok talking about it. And this is something which we should try and practice in order to avoid assisted vaginal births in general. But what is important is audit, where we must look at our own statistics. What is the rate of operative vaginal delivery, rate of failed operative vaginal delivery if you use sequential instrument? And mind well, the audit should not be performed only for an individual operator, but it is for the unit as a whole. And the sole purpose of having an audit is to improvise on our technique, give a better result to the mothers. So to conclude, informed consent is extremely vacuum extraction to 4 to 5, and here we really have to reassess after 3, assess advancement of presenting part or the initial with the initial or certainly the second traction, restrict the overall duration of procedure to less than 30 minutes, avoid sequential use of vacuum extractor and forceps, abandon any procedure that proves difficult, and please maintain the records. And this is the mnemonic which I personally like. This is by the SOGC, which says A is for anesthesia and assistance, ensure adequate pain relief, and we should have a good neonatal support. And when we say neonatal support, it is a person who is trained in resuscitating the neonate. Second is bladder. Bladder should be empty. C stands for cervix, which has to be fully dilated, effaced with the ruptured membranes. Determine the position, station, pelvic adequacy, and possibly shoulder dystocia. So you should be really well prepared. Equipments have to be checked. Check the cup, check the pump and the pressure. Fontanelle, because this is something the posterior fontanelle will tell us the flexion point, and we must sweep finger around the cup when we apply it. Gentle traction is important, and this has to coordinate with the maternal efforts. Halt the procedure, refer to the rule of 3. Incision, that is episiotomy. So consider episiotomy if laceration is imminent. Shaijas has already told all about episiotomy, but generally whenever we are thinking of assisted vaginal delivery, episiotomy is preferred. And last is the jaw. Remove vacuum when the jaw is reachable so that you know that the delivery is ensured. So thank you very much. Once again, thank you, Lakshmi. Thank you, Palani, for the opportunity to talk about vacuum forceps.
Thank you so much, sir. It was indeed a very elaborative talk on vacuum-assisted vaginal delivery, sir. So definitely, I'm sure a lot of people who have been participating in our webinar today would have been benefited and would try to apply these tips, tricks, and all the steps that you have just said in their day-to-day practice and see the outcome.
Thank you, Parag. That was fantastic. And it was so much complimenting to what Dr. Parikshit spoke a couple of minutes back. And that was fantastic. And as usual, that is why we call you. And I'm very happy that a lot of ICOG office bearers are here today to be a part of this ICOG webinar. And it is fantastic. And yes, thank you, Parag.
Thank you.
Parag, you would stay back because you will have to answer on behalf of Parikshit also. After Dr. Sampath's talk.
No, I'm here. I'm here.
Yeah, thank you. Yeah.
He's always there in the webinars.
So moving ahead to our next speaker. We have Dr. Sampath Kumari Madam with us, and she's Obstetrics and Gynaecology, MMC Chennai. She is also a FOGSI Vice President 2022. She is President Board of Studies, OG, Tamil Nadu, MGR Medical University 2015 to 2019. Member Board of Studies in OG, Meenakshi Medical University. Chairperson of FOGSI Adolescent Health Committee 2016 to 2018. ICOG Governing Council Member and Executive Member, IMS Chennai. She has a lot of awards to her name. FOGSI President's Award for Best Committee Activities, AICOG Bangalore 2019. IMA Doctors Day Award from IMA Tamil Nadu State Branch 2018. FOGSI Dr. Durusha Distinguished Community Service Award 2017. FOGSI Mr. N.A. Pandit and Mrs. Shailaja Pandit Women's Empowerment Award 2016.
Thank you.
Okay, thank you so much, ma'am. But there are plenty of awards to your name. And today we are going to hear deep transverse arrest, tips and tricks from Madam. Over to you, ma'am.
Thank you, Dr.
Just 1 minute, Sampath.
Yes.
We forgot to mention that Dr. Sampath Kumari was awarded Best Governing Council Member in the year 2020. So this
Yes,
is
in
something-
ICOG.
Yes.
Thank you, sir. Thank you, sir. Good evening to all. First of all, I thank Dr. Lakshmi Madam, Dr. Parak sir, and the Palaniappan for the wonderful opportunity. And this is important. I will share my screen first. 1 minute. Yes, Palani, can you see my slide?
Yes,
Yes, very well. Yeah.
Yes. So once again, I thank you. My topic given to me is deep transverse arrest.
Sampath,
Now
make
you
it
had the
slideshow.
wonderful talk.
Make it slideshow.
Yes, madam. Yes, madam. Yes, wonderful talk about the forceps by Dr. Parak. Now the same forceps will be helpful for our deep transverse arrest also. So what are all the tips? First, what is the deep transverse arrest? See, as all of us know, it is the failure of both rotation and descent of the head from a transverse position or just above the level of the spine. That may not be the rotation complete, and the descent is also delayed. So it is considered as the deep transverse arrest when the cervix is fully dilated. Previously, they were thinking that if it is not fully dilated, also deep transverse arrest. But as per definition, if the cervix is fully dilated and there is no rotation and there is no descent of the head with good uterine contractions, it is called as the deep transverse arrest. So this is the history. That is in 1779, Smiley and Montgomery considered this as the transverse small positions of the head. And in 1902 German textbooks, it was mentioned as deep transverse lie or the position. In the America, in 1907 by C.B. Reed, only considered this as the deep transverse arrest. But Dealey and Coghlan in 1927 in Australia, they told that it can be the low transverse arrest. So there was a confusion to tell us a deep transverse arrest and low transverse arrest. And Wilfred Shaw in British Journal, he has mentioned as deep transverse lie. With all this, finally, the British Journal and everyone accepted this termination as a terminology as the deep transverse arrest. Why the deep transverse arrest occurs? As all of us know, with the 4 types of the pelvis, it is very common with the android pelvis. Most of them is the convergent pelvic sides and the ischial spines projecting as we seen in the android spines and the reduced bispinal diameter and the sacrum when it is straight and the persistent fetal head deflection. This deflection and abnormal uterine contraction. These are all the causes which is the etiology for our deep transverse arrest. So why in the android pelvis the deep transverse arrest is common is because the more spaces in the posteriorly, hence head occupies the posterior part such that it comes to the occipito-posterior. So this is the deep transverse arrest where it comes as the normally occipito-anterior. Here comes the occipito-posterior position. What happens with this occipito-posterior position? Normally 90% will change into the occipito-anterior. That is different. Remaining the 10%, it will take a short posterior rotation by 1/8 of the circle and it will remain in the persistent posterior position. In that cases, the baby will be delivered as the face to pubis delivery. So when it takes, rather than the posterior, anterior rotation of 1/8 of the circle, it comes to lie in the bispinous diameter, interspinous diameter, there it becomes the deep transverse arrest. With the long rotation, as I told earlier, the 3/8 of the circle, it goes to the anterior position and delivers normally. If it is a non-rotation, again the oblique posterior arrest. In these arrest cases, most of the time they end up with the cesarean section. So the occipital posterior is the common cause which leads to the deep transverse arrest, which has to be diagnosed with the per-abdominal examination itself. But most of the time we don't diagnose in the per-abdominal examination, only in the second stage of labor, the deep transverse arrest is diagnosed. This is the algorithm, that is engaging diameter is occipitofrontal 11.5 centimeter or suboccipitofrontal 10 centimeter. When it is favorable, 3/8 rotation in 90% of the cases, it turns to occipito-anterior and normal delivery with extension and all the mechanisms are. In the unfavorable condition, mild deflection, that is rotate by 1/8 circle anteriorly, goes to the deep transverse arrest. Posteriorly, it goes to the persistent occipito-posterior, and non-rotation, it presents as oblique posterior arrest. So this can be the face-to-pelvis delivery in the multi. And if it is the arrest means we have to go for the cesarean section. So what are all the ways which can be delivered? The tips we can see. So how it is diagnosed, this deep transverse arrest? As I told, the incomplete forward rotations of the occipito-posterior position and the failure of the head, which enters in the occipito-transverse position to rotate anteriorly. So this forward rotations at the head to rotate anteriorly is failed, so that the deep transverse arrest occurs. Mostly in the second stage of labor, head is engaged, sagittal suture is at the level of the ischial spine, and the no progress even after 1 hour full cervical dilatation. Then we consider it as the deep transverse arrest, and how are we going to deliver the baby. So by as examination, head is deeply engaged. By the per-abdominal examination, by pervaginal examination, head at the level of the ischial spines. If the caput and molding, everything is present, it will be difficult to diagnose the bisagittal diameter, which is in the bispinous diameter. So commonly, it is present in the android and the anthropoid pelvis. How are we going to manage? Most of the time, in the case of the android pelvis, where it is diagnosed of the deep transverse arrest, that is no progress with more than 1 hour of full dilatation, it is better to go for an emergency cesarean section. But other methods which are all possible for the deep transverse arrest are the vacuum delivery, which is performed sometimes, and the manual rotations by the hand and then delivered by the forceps, and the rotation by the keel and forceps, which are not doing now. But for the completion, we have to know what are all the other methods by which it can be delivered vaginally. Normally, the vacuum extraction is performed. By the vacuum extraction, what it happens, it promotes the flexion. As such, it reduces the diameter at the outlet from the occipitofrontal to the suboccipitopragmatic. There is no need for anesthesia in these cases. The cup is applied near the posterior frontanella to promote flexion and the smooth descent. See, these are all the cup. The cup selection is very, very important. Proper cup placement is essential, and selection of an appropriate cup is important. And the rigid vacuum cup is advantageous than the soft cup because it allows the traction to make the possible for the traction. Rigid vacuum will be better than the soft, by which we can also go for the auto rotation from the occipitotransverse. These are all the flexible stem permits placement and movement of the device within the limited space of the vagina. Although the rotational force, these are all the theories, so this alone is enough. The vacuum extractor itself should not be manipulated to rotate the head. So with this help, we can try to rotate, but fully with the vacuum, rotation will be very, very difficult. Then comes the manual rotation. That is the manual rotations is with the hand. It can be the full hand inserted or with the short hand insertions. So by this, what we are going to do? An attempt of manual rotations, the appropriate, the gynecologist should be well expert to do this manual rotations. If they are not expertise with this procedure, better to go for an elective LSCS. But it has to be tried mostly with the multi-pair aspiration rather than with the primary patients. So by this rotation, what happens? With this rotation, the natural auto rotation, when it fails, we are creating these rotations with the manual rotation. You should be very, very careful, not injuring to the genital tract. So the manual rotations, the rotations of the fetal head from occipito-posterior to occipito-anterior by introducing the hand into the vagina. For this to do, the liquor should be little adequate, and the baby size should not be the macrosomia baby, and the pelvis, as we have assessed already, it should be adequate. Then only we can go with this procedures. So what happens with the whole hand and the partial hand? With this whole hand, if it is the right occipital posterior, better to use the right hand, and the left occipital posterior, left hand will be convenient. Before that, a slight disimpaction of the head should be done before the rotation. Then it will be easier for us. Thumb on the anterior pantalla, that is near the infant temple, and other four fingers like this, other four fingers over the posterior bone near the other infant's temple. So head is grasped by temporally. So head will be grasped with the thumb and the other four fingers with the bitemporal. Then it is rotated by the supinations. At the same time, you can ask other persons to mother's flank, promoting the rotations of the trunk. Simultaneously, the trunk rotation is also to be done with the pressure. If it is done, then after this rotation is completed, you can deliver the baby with the forceps, a normal forceps. Alternatively, again, thumb can be placed on the occiput and the four fingers over the incipit. This is the whole hand method, which has to be done for the rotation of the baby. This is half hand method. Suppose if the whole hand is not able to go inside. So what we can do, the four fingers is introduced into the vagina and the thumb can be kept at the occiput level. And the pressure is applied at the head at the level of the engaging diameter. When you give the pressure and the four fingers were introduced into the vagina, preferably right hand will be comfortable. So these are all the methods which can be tried. You cannot repeatedly try. If you are well exposed, well versed with this procedure, you can try. Otherwise, you cannot get a chance to try. Otherwise, the baby can go for the distress and there can be the injury to the genital tract. So you should decide and appropriate case, appropriate procedure, you can do this manual rotations. This is the same thing, right hand grasp between the incipit, which increases the flexion, and thumb and the finger, as I told, it has to be called. This hand grab method, the full hand method and the whole hand method and the half hand method, why it becomes failure? Suppose if you are not able to give a incipit grip, if the grip is not comfortable, then it may not be possible for you to rotate. And the head, the disimpact, the head should be little disimpacted before the rotation. If it is not possible to do, again it can be failure. And the hand, if the hand is not able to insert, if you have selected the wrong case and the pelvis is not adequate, in that cases also the hand rotations will be failure. So these are all the methods which can be useful for the rotation. Again, there comes this feel, and once the rotation is over with the mid forceps, you can deliver it. This keel and forceps, this keel and forceps is applied in the AP direction and rotation is carried out with the keel and forceps itself. This is designed, how this keel and forceps is designed means without a pelvic curve and with the sliding lock to improve the rotational procedure. But nowadays this is not done. Previously it was done. I have never seen the cases with where the rotation is carried out with the keel and forceps. Here the toes, blades, shanks and handle will be lying along the lock axis. So with this shank, we should rotate and deliver the baby. This other, as I told, the manual rotation, when it is done with the hand, with the mid forceps, you can deliver the baby with the traction. That is traction to the fetal head with forceps. Now you had the fantastic talk of Dr. Parag with telling about the forceps, what are all the indications, and the vacuum cases, what are all the indications that assessing the case and identifying the case which can be fit for forceps or vacuum is very, very essential. So these are all the methods which we are going to rotate the methods. This application, forceps locked outside with the knobs towards the occiput to know the anterior blade. Sometimes anterior blade is guided in the lateral side of the pelvis with the cephalic curve facing the fetal head. Slide over the forehead to fit against the frontal eminence. So these are all the different methods with the keel and forceps and the mid cavity forceps with the locking side. With the different methods, whichever is comfortable, we can do and rotate the with the forceps and deliver the deep transverse arrest baby. So which are all the cases of exclusion where nothing can be tried? As all of us know, the CPD cases, previous cesarean section, bro or face presentation, the CTG when there is a difference of the baseline of more than 160 per beats, fetal scalp pH less than 7.25, lactate more than 4 mmol, known or chorea amnionitis if it is present, intrapartum hemorrhage is present, febrile temperature is more, and the existing diabetes, suspected fetal bleeding disorder, a major anatomical fetal abnormality. These are all the cases, nor we should not take the chance of doing these rotations and forceps. In that cases, it is better to go for an LSCS. So now coming to the LSCS, the lower segment cesarean section for a case of deep transverse arrest. Already the patient has the full dilatations and 1 hour we are waiting. So how the delivery of the baby will be very, very difficult since it is deeply engaged and in the deep transverse arrest. How the tips to deliver the baby, how it can be. That is the push technique, and it can be a pull technique, or it is the Patwardhan technique. Nowadays, most of the time, all of us are following only this Patwardhan's method, the push technique and the pull technique. Most of the times we are not following. Previously, we used to do the push technique. Now, this Patwardhan method is very, very comfortable to deliver the deep transverse arrest. In the push method, what we are doing with the one hand, we are going to push the baby from the vagina. That is, an assistant places the glove, cupped hand into the vagina to gently disengage and push the impacted fetal head up into the uterus, such that it can be extracted via the cesarean birth. 3 or 4 fingers are separated and spread over a large area of the fetal skull to avoid exerting excessive focal pressure, which can be the traumatic. This is the push method we are doing. The operating obstetrician also assists from above by providing steady upward tractions on the fetal shoulders. When we are pushing from the down, there can be upward traction with the fetal shoulder, such that attempting to flex the fetal head or prevent the further deflection. That can be, flexion can be assisted and deflection can be prevented. These are all the Whitmore and the frog position. Push method. If you are somebody's, if you are not well versed with the Patwardhan methods, the push methods can be done. If you don't have an assistant for the push method to do, that is a person who does not know how to do the push method. In that cases, the obstetrician can change the gloves. The task can change and she herself resuming the trans-abdominal procedure. That is, in the absence, the primary obstetrician uses the trans-abdominal hand to prevent further deflection and places the other hand in the vagina to push up the head. If the assistant is not there, the same surgeon can do it, but change the gloves, and after the baby's head is pushed, again you change the gloves and continue the procedures. So what are all the complications can happen with this push method is, if you are not doing the method correctly, then that can be the extensions of the uterine incision. That can be uterine incision can extend, the corner can, bleeding can be present. So it will be difficult to catch. And sometimes the fetal morbidity can happen, such like a skull fracture, and again the postpartum endometritis. So for every procedures, there are some disadvantages. So we should be very careful on selecting the cases. Nowadays, this fetal pillow, this is used comfortably. That is for the disimpacting system, the fetal pillow. It is a silicone balloon that can be inserted through the vagina to rest under the fetal head. And it can be inflated with the saline in an attempt to elevate the fetal head. It is inserted and the saline can be pushed such that the head can come up and baby can be delivered. This is the fetal pillow before inserting, how it is, insertion, how we are going to do, device position, and the inflation, how we are going to inflate it. Then the baby head goes, cesarean section, and the device is removed. Fetal pillow, we don't have that, since in our government hospitals, we don't have this fetal pillow, but many obstetricians are comfortable with using this fetal pillow. So this is for mainly for the disimpactions. Sometimes nowadays, even the forceps can be used. Now, in a case of LSCS, when you are using a forceps, always don't prefer to use a single blade. Better to use the 2 blade and lock, and better to deliver it. So with the single blade, when it is used, it will be used to elevate the head and deliver. So with the forceps also, baby can be delivered. This is the this I got from the literature, that is C snorkel. That is, C snorkel is an anatomically curved tube with multiple ventilation ports, it seems. It can be inserted between the vaginal wall and the fetal head, and aeration through the port can alleviate the vacuum can be created, and it will push the head above and the baby can be delivered. I have never seen this C snorkel. So the push method can be done, but with all this method, fetal pillow and the forceps. Pull method, in this case, if you don't want to, if you are afraid of this endometritis and the vaginal infection, if it is going, in that cases, you can go for a pull method. What is this pull method? Here, the lower vertical hysterotomy for planned reverse, it is nothing. We are going to deliver by the breech extraction. Rather than going to push from the below, you are going to do the T or J incision and deliver, catch the foot and deliver by the breech extraction. So the operator hand is inserted into the uterus toward the fundus to grasp the feet. Better to grasp both the foot. Then it can be delivered as the breech extraction. When grasping and pulling the feet, the care must be taken again. When you catch, we should be very, very careful and pulling again, that can be the fracture, morbidity to the baby. Again, the extensions in the case of the LSCS. Once the feet means one feet is, if you can't also bring that feet and push it, you catch hold of the second feet and deliver the baby. This is the pull method. The push method is from down. Pull method is delivering the baby by the breech delivery. Here comes the Patwardhan method. This Patwardhan method, it is very, very easy. Better to have the incision that is will be near the shoulder region only. So the anterior shoulder is delivered along with the anterior arm by hooking a finger in the elbow if required. Then what with the gentle traction, what we are going to do this, we are going to deliver the posterior shoulder is then delivered. First anterior shoulder and then the posterior shoulder we are going to deliver. Then the trunk and the breech, buttocks. So the trunk, when you lift it, the trunk, buttocks are delivered, followed by the legs. And finally, the head which is engaged can be delivered. So first with the hook, deliver the anterior shoulder, then the posterior shoulder, trunk, with the, then the legs, and finally the head can be delivered. The modified Patwardhan method, what they tell is anterior shoulder and the same side, upper and the legs, afterwards trunk, and then with the opposite side. But this Patwardhan method is nowadays, even the PGs are well trained, because we should train the PGs to do how this Patwardhan method is very, very useful without going for extensions of the LSCS incision, and there is no morbidity to the baby. So this Patwardhan method is the best method to go for the. I had some video. This is for the occipital posterior. I don't know whether it is. So demonstrate how the baby with the occipital posterior and comes to get engaged in the deep transverse arrest. That is in the transverse bispinous diameter. The sagittal suture will get settled. And after the dilatation, again, if it is not means no contraction was not sufficient and there was no progress means it will get settled, and this is the way the deep transverse arrest occurs. So manual alteration, if you are well versed, you can do, and the keel and forceps nowadays it is not done. So if the deep transverse arrest, better to go for LSCS is the best procedure as for on day to day. Okay. Now the tips means, now if you have considered diagnosed as the deep transverse arrest, better to tell the patients that is communication is very, very important. Call for help and get the support. One-to-one care is very important, and comfort and pain relief. Always if you need it, if the patient is comfortable, you can go even for the epidural earlier itself. And the ambulation and position, assessment of the progress, partogram is very, very important. Nowadays, other methods are also available. Effective assessment of the maternal and fetal well-being, appropriate and decisive clinical decision. Appropriate if you are not able to do the cases means, if it is in a setup where you don't have the facilities or NICU center, better to refer the case to the higher center at the earlier period. And record keeping is very, very important, and careful deferring following the birth of the baby. This squatting exercises with this deep transverse arrest, this only one literature I saw where they were telling about the squatting exercise also, but we don't have time to do that squatting exercises. Better you go for a manual rotation or go for an LSCS. So in a case of deep transverse arrest, diagnose it earlier, don't get delayed, and treat it immediately. Whatever procedure you are comfortable, do it. If procedures, if you are not comfortable, go for an elective emergency LSCS. And if you don't have the facilities, refer the case earlier, such that morbidity and mortality of both mother and the baby can be prevented. Thank you once again, Lakshmi Madam and Dr. Parani. Thank you for the wonderful opportunity.
Amazing talk, madam. It was really very enlightening for all of us. I'm sure all the participants today in the webinar. There were too many things to learn, too many take-home points. All the sessions were excellent. Thank you so much, ma'am.
Thank you, Sampath, madam. And there are actually not much of question answers on the blog here, but there are a few comments and clarifications, and so yes, and there are many comments done by Dr. Mitra Saxena and a lot of other people out here. Yes, they've given their views on how to do the delivery on deep transverse arrest. And a lot of appreciations for Dr. Parag, Dr. Parikshit, and Sampath Madam yet to get, because I'm sure they will be typing the messages quite well. Yeah, Dr. Lakshmi, over to you while they put on the questions.
So I am too very happy as far as today's masterclass is concerned. All the speakers, they gave so much practical tips to our attendees. I'm really happy, and as far as the discussions were going on about forceps and ventus, and that was expected also, it is because our youngsters are really not trained in forceps and ventus. There is a place for instrumental delivery even in this modern day obstetrics, even in this litigation era. As Dr. Parag and Parikshit were highlighting, you should know the indications and you have to follow all the tips and tricks which Parag has highlighted in their mnemonics, and the role of consent and all the precautions. So all said and done, all the medical teachers are here. So many of our ICOG fellows are here. And I saw that there is a demand also that ICOG should conduct a certificate course also, which I will definitely consider. But yes, it is mainly the role of teachers to teach them the art of instrumental delivery. And as Sampath was talking about the Patwardhan method, the deep transverse arrest. So today's masterclass was on practical tips, and Shaijus, fantastic. I think everyone has agreed for, I don't know, maybe most of them have agreed for selective episiotomy and not routine episiotomy. And Ashok gave very good talk on labor care guides. And the second talk, Dr. Akila gave on epidural anesthesia. So Palani, you have really covered the labor room today in your this ICOG masterclass on labor, laborious or not. That I think Parag, I will ask Parag only as a vice chair ICOG also and as one of the expert speaker. So what are his comments on today's ICOG masterclass, and today's the theme which Palani has chosen?
Right. Lakshmi, being a hardcore obstetrician, there is always a bias. Whenever there is something related to obstetrics, I cannot resist. So when Palani asked me to talk on vacuum, I said, okay, I'm going for it. I think this is something which we obstetricians and gynecologists need day in and out. And I think all the topics were very well covered. I'm not boasting because I was one of the speakers, but you know, even Sampath's presentation, yes, she gave a balanced overview with a very clear-cut message that C-section is the safest, right? So I think even Parikshit gave very important tips, and the video was definitely something which was worth watching for. So Palani, I think we must compliment you as the convener, that you've chosen the right people to talk today, and I hope everybody enjoyed all the presentations.
Yes, Palani, back to you before we end. Yes, Sampath, you want to say something?
No, I want to thank everyone. That's all.
Oh, no. Your talk was very well taken and with lot of take-home messages. So if there are no questions,
Lakshmi, there is one question by Abhijit Deshpande: how to deliver during LSCS when the fetus is dorso-posterior with head deeply engaged?
You can answer.
Yeah. Okay. Now, see, whenever we talk about Patwardhan's technique, there are two methods which were described by Dr. Patwardhan way back in 1955. So when the back is anterior, there's one maneuver, and the question that Abhijit has asked is when the back is posterior. So when the back is posterior, we cannot deliver both the shoulders. So we deliver the first shoulder, then we put a hand inside, deliver the breech, deliver the trunk, then comes the second shoulder, and eventually we deliver the fetal head by dislodging. So this is something called Patwardhan's method when the back is posterior. And Dr. Sampath has already described the procedure when the back is anterior. So we deliver both the shoulders first, then comes the trunk, the breech, and eventually the fetal head.
That answers all the questions here. And I'm sure there are no questions. If there were questions, I'm sure people would have put by then, because I thought the ICOG masterclass, they're all tuned to getting done by 6:30, 6:35, though we say 7 o'clock. And that was excellent. And all the 6 speakers did a wonderful job in their own ways. And the ones who did not attend today's masterclass, oh, they missed something. They missed something, and it was a fantastic treat to watch all of them speak on the expert topics. And after having said that, I would say, oh, labor is not laborious. It is very easy to do so. And
I was expecting that answer from Palani only. So after today's masterclass, it is not laborious. Yes.
It is not laborious. It is actually a very nice course of labor if we follow the tips and tricks which our stalwarts have given. And thank you, Dr. Lakshmi, and looking forward for the next ICOG masterclass on the next month. Maybe it will be on gynecology, and I will work out a program and get back to all of you. And I thank Dr. Alka for moderating this master of ceremony show, and of course Dr. Lakshmi, who's always I'm indebted to, for having given me this wonderful job, tough job, but a wonderful job to do so. And thank you very much. And Mithali and Sonam and Neelima from the ICOG FOGSI office, thank you very much. And of course, Parag, the vice chair of ICOG, and Ashok, secretary. Thank you very much. And it was fantastic being with all of you. And I hope this session was very useful to all the delegates. Over to Dr. Lakshmi for the concluding remarks.
No, I mean, it has went off well. As you said, everyone is asking for the recordings. We will see to it that it gets uploaded on ICOG website shortly for those who missed it. But live class is a live class. You get to interact with the faculties, and what you understand in a live class is different from what you learn from a recorded class. So that makes all the difference. But nevertheless, it will be available on ICOG website. And if there are no questions, with profuse thanks to Palani and special thanks to Parikshit, we would like to take your leave, and we will meet again next month for next ICOG masterclass. So Mithali, you can stop the recording, and we can say good night, and we will meet again. Yeah, you can end the meeting also.
Good night.
Thank you so much, ma'am. Thank you, Dr. Lakshmi.
Thank you.
Thank you.